the stream.
Got it.
1 second.
And then I also have like a bio that I was just going to read for you to introduce you.
Okay, thank you.
Yeah. But Liesel, did you want to kind of give a brief one-liner about who we are and part of PhilPro? Or Dr. Gandhi, just to...
I can. I don't know. You have to cue me, but we are streaming live, so I'll have you guys kick off.
Go ahead. Go ahead.
Sounds good. All right. Well, we can go ahead and play our first promotional video, and then we can get started with introductions after.
Okay. You want me to go ahead and play the video? Okay.
Magandang umaga sa inyong lahat. Good morning, everyone. Thank you so much for coming to today's webinar, Usap Tayo. My name is Diana De Rosarios, and this is Matt Rosas, and we are part of the Filipino Young Leaders Program, also known as PhilPro.
On behalf of PhilPro and Tayo Help Desk, we have the pleasure of co-hosting this with our very own Dr. Isa Palma and our amazing president, Liesel Tanglao. Special shout out to our partner, GMA Pinoy TV, for their support. GMA Pinoy TV is celebrating its 17th year, and to all our subscribers here in the US, thank you very much for the support. Let us all stay stronger together. To know more, visit gmapinoytv.com/subscribe or follow us on social media at GMA Pinoy TV.
Today, we have a special guest, Dr. Monica Gandhi, who will be talking about COVID-19 boosters, especially on the latest updated booster that targets Omicron subvariants and related resources, and latest information on the 2022 monkeypox outbreak. We will then conclude with the Q&A session, which will also include our other esteemed guest, Dr. Franco Filizarta. Dr. Filizarta received his medical degree from the University of the Philippines College of Medicine. He completed an internal medicine residency and an infectious disease subspecialty residency at the State of New York Health Science Center at Brooklyn. Dr. Filizarta is in a solo private practice in Bakersfield, California. He is an HIV specialist at the Kern County Department of Public Health, Santa Barbara Public Health Department, and the Omi Family Health, which is from Kings and Tulare counties. He's also an ID specialist at the Community Health Centers at San Luis Obispo County and California Department of Corrections and Rehabilitation Telemedicine Program. He is also the director of the Antibiotic Stewardship Program at Bakersfield Memorial Hospital from Dignity Health and a member of the Kern County Medical Society of Board of Directors.
And it is my pleasure to introduce our first guest, Dr. Monica Gandhi. Dr. Monica Gandhi is a professor of medicine and associate division chief of the Division of HIV, Infectious Diseases, and Global Medicine at UCSF San Francisco General Hospital. She also serves as the medical director of the HIV clinic at SFGH, also known as Ward 86. She completed her MD at Harvard Medical School and then came to UCSF in 1996 for her residency training in internal medicine. After residency, Dr. Gandhi completed a fellowship in infectious diseases and a postdoctoral fellowship at the Center for AIDS Prevention Studies, both at UCSF. She also obtained a master's in public health from Berkeley in 2001 with a focus on epidemiology and biostatistics. Dr. Gandhi's local and national presence has been instrumental throughout the course of the pandemic. She's been recognized as a voice of compassion, reassurance, and reason. Her decades-long commitment to social justice and equity has long been valued, and most recently as a recipient of the 2022 James C. Hormel Community Spirit Award by the internationally recognized Shanti Project, based in the Tenderloin of San Francisco. Without further ado, I'd like to introduce you to Dr. Gandhi. And
Thank
go
you.
ahead, feel free to share your slides.
Okay, great. Thank you. It's really nice to be here. And again, sorry about this morning, technical issues. Okay, so I'm going to talk a little bit about COVID and the boosters, but I want to give a little bit of history of COVID as well and where we are in the state of the pandemic. And, you know, it's been a very difficult 2.5 years. And unfortunately, I always start every talk about pandemics with the fact that I think global warming, our treatment of animals, our changes in agriculture, our encroachment on animal habitats are all going to set us up unless we work sort of better together on these big social problems for more pandemics, because this is really an era in which pathogens are moving to different places to get out of the way of heat, and our interaction with animals has been really problematic. And if we think about the beginning of this entire thing, we actually had other coronaviruses that caused severe disease. There have been 2 other pandemics in the last 20 years that were really coronaviruses coming out of animals. So the first one was SARS, 2002, 2003. It was much more limited than this. It was 8,100 cases, and there were 29 cases in the US, but it was a coronavirus that caused severe disease, and it ultimately came from the bat through this animal called the palm civet and came into humans. And that was a much more limited pandemic. And so was the second time that this happened, which was MERS. This was a coronavirus that also came out of a bat, went through the camel, and actually was mostly in the Middle East, 2,500 cases, and then went into humans. And it was also very limited. And then we all know the history of SARS-CoV-2, because this was reported first from China, Wuhan, on December 31st, 2019 to the WHO. By January 7th, it was identified as a new coronavirus. And by March 11th, this was declared a global pandemic. US became the epicenter of the pandemic on March 26th. And by December 11th, we had the first vaccine for COVID-19. December 11th was the emergency use authorization. But unfortunately, there have been 6.59 million deaths. We don't know the true etiology of where this came from. We think it came from a bat. We think it has to do with the wet markets in Wuhan, which is really this idea of putting animals together that usually aren't seen in nature together. But we also know, and I refer you to this commentary by Jane Goodall, that our unhealthy relationship with animals and our treatment of animals is going to contribute to diseases. So let's talk about the vaccines, and let's talk about the variants. So we actually in this country have 4 of these vaccines, but it's important to remember that there are 9 vaccines that are out there that are great. The WHO has not approved Sputnik 5, which is the Russia vaccine, but all of them work really well. And the 4 that we have had in this country are Moderna, Pfizer, Johnson & Johnson, and now Novavax. And if you look at this list, the first 6 all involve the spike protein of the virus. And then the bottom 3, Sinopharm, Sinovac, which are in China, and the Covaxin vaccine, which is in India, all involve looking at the whole virus. So they're all called whole virus inactivated vaccines. And what do we mean by spike protein vaccines? Well, remember, the virus just has this little piece of it that sticks to the host cell chromosome. That's the spike protein. And those 6 top candidates all involve either coding for the spike protein, or in one case, giving the spike protein itself. So we've become very familiar with this technology. But the 5 that code are the Pfizer and Moderna, and they actually take the mRNA that codes for the spike protein. You in your body then take that mRNA, translate it into a lot of that spike protein, and then you raise a powerful immune response against the spike protein. So this will be the basis for when we talk later about emerging variants, that you can actually change the mRNA of that spike protein and adapt it to variants. So those are the Pfizer and Moderna. What about AstraZeneca, Johnson & Johnson, and the Sputnik 5 vaccine? They are all DNA vaccines. So what that means is that they're enclosed in a benign adenovirus. The DNA goes in there, that DNA gets made in, you make that DNA into mRNA, and then you make that spike protein just like you did before, and then raise an immune response to it. We only have the Johnson & Johnson in this country. And then finally, there's one more spike protein vaccine, which is the Novavax, which actually just got approved for a booster in this country. And it's very traditional vaccine technology. It's just a protein with an adjuvant, no genetic material, just the spike protein itself. And remember, when we think about, and this is very relevant to the booster conversation, when we think about what is the immune response to vaccines? I think the media has done a huge disservice by saying immunity is antibodies, because antibodies are just one aspect of immunity. And what these vaccines raise is they raise T cells, which are actually the main arm of the immune system, specifically the Th1 CD4 cell response, fights viruses. And they also raise B cells. And what do B cells do? B cells make more antibodies aided by T cells if they see the virus again in the future. So what we need to know is who needs antibodies right away, which is how we determine who needs boosters usually, and who can rely on the cellular immunity raised by the vaccines, the T cells and the B cells, to, if they see the virus, respond to the virus. Now, how do we know that these vaccines actually raised T cells? Because even though we never measured T cells for other vaccines because T cells are very hard to measure, we had the technology in the year 2020 to do so. And so if you look at column 4 of this table, all 6 of these vaccines, the spike protein vaccines in their phase 1-2 trials in humans, measured T cell responses to the vaccines. And T cells, again, protect us from severe disease, such that in column 6, the yellow one, you can see that the protection against severe disease was really powerful. In fact, it was almost 100% against hospitalization and death in the clinical trials for all 6 of these vaccines. And that was true of even all 3 of the whole inactivated virus vaccines, which are, again, used in other countries and we don't have here. So if T cells protect us against severe disease, aided by B cells, which produce more antibodies, then how do boosters work and who needs boosters? Well, one thing about the antibody responses is as the spike protein has changed, because why has the spike protein changed? The spike protein has changed because this is the particular piece of the virus that actually makes the virus more transmissible. And the virus wants to make more baby copies of itself. So essentially, evolutionarily, the virus has become more and more transmissible over time by evolving mutations in its spike protein. And we'll talk about variants in a minute. So the antibodies that you generate from the vaccines don't work as well against the spike protein because they form protection against the spike protein, and the spike protein has been changing. But how do we know that our T cell responses are still staying preserved against the spike protein? We know this because there have been many studies that show that even with Omicron, even with the new variants, there is such a in-breadth and robust T cell response across the spike protein that you actually generate from the vaccines protection from the viruses, protection from the variants, even from the original vaccine boosts. So that SARS-CoV-2 vaccination induces T cell immunity able to cross-recognize any variant from Alpha to Omicron. And then what the B cells do, and this is very important, is once your antibodies go down with time, because if say you got your last vaccine last May, your antibodies are going to fade. They are going to wane because we can't keep in our bloodstream the antibodies to every cold, to every vaccine, to every infection we've seen. That's too much protein. So they'll come down with time, but your memory B cells are the recipe book to make new antibodies aided by our T cells if they see a new variant in the future. And they don't make antibodies directed against some old variant. They will adapt the antibodies they produce and make it against the variant they see, which is why 2 doses were very protective for many people, at least against severe disease, up to this point. So what about the new boosters? Well, let's talk about the variants first for a minute. So this virus, March of 2020 was when it was first, it was declared a pandemic, but actually there was a variant over the summer of 2020 called the D614G variant that we didn't label with a Greek letter. After that, the variant started getting labeled with Greek letters. And the first one that we really saw in this country was late 2020, early winter 2021, which was Alpha variant. And that was much more transmissible than the old, what we used to call the ancestral strain. Then there were 2 other variants, Beta and Gamma, that weren't very transmissible. So they actually stayed relatively constricted to where they had been described. And then there was the Delta variant. The Delta variant was first described in India. It was in March of 2021 in India. By July of 2021, it started becoming our dominant variant in the US. And that was unfortunately more transmissible than Alpha, but it was not less virulent than Alpha. And that in unvaccinated individuals in the US did cause a lot of hospitalization and death. Now, what about Omicron? So Omicron, I think we all remember, it was Thanksgiving Day when Omicron was described. And Omicron was described from South Africa. It's a very interesting variant in that it is definitely more transmissible than Delta, but it does seem to be, by multiple findings, less virulent than Delta. So it's more transmissible, more variant. And at this point, less virulent. And at this point, a modeling organization in Seattle, the Institute of Health Metrics Valuation, has estimated that 75% of the world's population has seen Omicron. It is that transmissible. So we have a huge amount of natural immunity that has occurred from Omicron. It is also, again, less virulent, but that doesn't mean that in older people it wasn't virulent, meaning if you had no immunity to Omicron, vaccination really, really mattered. So this is a graph from the CDC that shows that even during the first Omicron surge in this country in BA1, that it was those who were unvaccinated who were much more likely to be hospitalized with Omicron during the Omicron surge than those who were vaccinated. After that, there was so much natural immunity that, to be fair, these curves have actually converged more, and unvaccinated and vaccinated people are looking very similar in terms of their rates of hospitalization. And where is hospitalization occurring? It's really occurring in older people. So let me explain that, and let me explain who did the boosters benefit. Well, before we get to actually a fourth booster, let's look at this very important paper that got published in The Lancet on October 18th. And the reason that I think this is such an important paper is this paper looked at 30 million individuals across the UK who had received 2 doses of the vaccine. And they asked the question, who benefited from getting the initial booster, from getting that third shot or that first booster? And what they found is that actually those who were younger, especially under 50, had 0 benefit from the booster, meaning they were not going to be hospitalized from COVID-19 with 2 doses. And actually the people who benefited the most were divided into 4 categories. Older people, actually specifically older than 80, individuals who had 5 or more comorbidities, people who were living with chronic renal disease, and those who were on immunosuppressants. They were the individuals who were most likely to benefit from that third shot or first booster. And this is mirrored in other data from Israel. That was from the UK. But in Israel, there was a study that looked at that third shot. This was published in January of 2022, and found that it was really those over 65 that benefited from the third shot in reducing hospitalizations. In fact, those 18 to 29 years old had 0 benefit from the third shot. There were 0 deaths and hospitalizations in those who had 2 doses, and 0 deaths and hospitalizations in those who had 2 doses. And then a New England Journal study in Israel looked at healthcare workers and looked at the 4th shot, and actually found no evidence for benefit for the 4th shot for those under 60 years old. And so Europe and the UK have been actually suggesting this now 5th shot that we have, which is an Omicron specific booster for older individuals, for over 65, for over 70 in some European countries. Only the US has actually recommended it from 5 onward. So when we put all this data together, and I wrote a piece with an infectious disease doctor at Tufts, we put together the data and we published this in Lancet Infectious Disease, talking about the new boosters. And the new boosters are interesting because they have the ancestral strain mRNA in them, which is unfortunate because that ancestral strain is long gone. And then they have the mRNA coding for BA4, BA5, because the waves have been BA1, BA2, BA2 12.1, and then we've had BA4, BA5, and now we're getting into new variants, which are called BQ1, BQ1.1, and XBB. So the variants of Omicron keep on coming, but they're all Omicron. So what we wrote in this paper, and we put all the data together, and I'll actually send you the paper, is that the new boosters absolutely do increase antibodies. In fact, there was just a data release from Pfizer yesterday that they did increase neutralizing antibodies, but that increase actually only occurred in those over 55. Why? Because probably younger people, their own getting any boost, or just as they're living with their other vaccine doses, have enough antibodies, have enough B cell responses to respond to respond to a variant if they see it. But older people need antibodies refreshed essentially most often because it takes B cells about 2 to 4 days to make new antibodies. And if you're older, you may not be able to wait that long for your T cells to protect you. You need fresh antibodies to protect you up here in the upper airways. So we do really recommend, consistent with other countries, not with the US, but consistent with recommendations from other countries, that who needs this booster the most, we're actually recommending it for those 65 and older. And even though this country is recommending it for a whole swath of the population, I doubt that will actually occur every year. And what do I mean by that? And then I'll come back to this. What the WHO is recommending from now on is not boosting everyone every year, but boosting only vulnerable people every winter. And I'd be really happy to take questions about this after this talk, but their recommendation on March 30th, 2022, when they said that we have to downgrade from the emergency phase of the pandemic, we have to live with this virus, which I'll explain in a minute because of we can't eradicate this virus, is their base scenario was that if we stay with Omicron, which we've stayed with so far, we haven't had a new variant, that we're going to vaccinate or boost vulnerable groups every winter. Vulnerable groups usually include people with comorbidities, on immunosuppressants, and older individuals. They also laid out the case that if we had a less virulent variant that emerged, we wouldn't need to boost anyone because that would become everyone's boost. And then they also laid out the case of the worst case scenario. And that's if we got a variant that was more virulent. We have not gotten that so far. But if that happened, everyone would need a boost. And I mean, everyone from 5 on or from childhood on. And who would need, what kind of boost would they need? It'd probably be the vaccine that's available in your country. But in this case, we would definitely boost with the updated Omicron specific vaccines. So let's go back to something about another important thing that we wrote about in this paper about when to give boosters, because I certainly think there's no harm in younger people getting the booster. And we're going to talk about some side effects in a minute, but definitely older people need it. They really do need it because they're still the individuals who are most at risk from getting severe COVID-19. And so when do we give the booster is something else that we covered in this paper. And the important thing, and we've really learned this through this pandemic, but this is things that we knew before, is the longer duration that you have between doses, the better immune response you have. Actually giving a booster or too soon after your prior booster or even after a prior infection will actually abrogate the B cell response. And that is data from the NIH. So we really recommend waiting 4 to 6 months, and preferably 6 actually, after your last infection or after your last booster to get this next Omicron specific booster. And at this point, when I say after your last infection, there have been a lot of new infections because again, we're at a point about 75% of the planet has been infected with Omicron. For example, in this country, 80% of our children between the ages of 0 and 17 have evidence of natural infection to COVID-19 as evidenced by the circulating nucleocapsid antibody, which just shows that that's natural infection as opposed to spike antibody, which can be with natural infection or the vaccine. And really what Omicron also seemed to show us is the power of hybrid immunity. I always encourage those who are unvaccinated but had natural infection to at least get 1 dose of the vaccine. And those who have been vaccinated and had natural infection on top of it, that is a very powerful form of immunity. And we're labeling this hybrid immunity because really it seems to be the most powerful protection is to have seen in a way both, and so many people have. So where are we in the pandemic? And this is what I'm going to end with. Well, we actually are at the point in the pandemic where we're at our lowest numbers of deaths compared to where we were in March of 2020. We haven't seen these numbers of deaths across the planet since March of 2020. On September 14th, 2022, the WHO said that the end of the pandemic is in sight. But they rightly said that this pandemic, even if we declare the emergency phase of it over, which is what they're talking about, we'll always have to live with COVID-19. And that's why our booster strategies and our treatment strategies will always be with us. Because what I really want to talk about is endemicity. And I'm going to come back to schools if we have time, actually, but let's talk for a minute about endemicity. Why do we know that we can't eradicate COVID-19? Well, one thing that we have to remember about infectious disease epidemiology is there are 4 phases, and most infectious diseases are not actually eliminated or eradicated. Elimination means it's gone in a region. Eradicated means it's gone worldwide. And control essentially is reducing the disease to levels that are consistent with other pathogens of its same type. Now, we have only eradicated one infection in humans. We've eradicated one called rinderpest in cattle, but that was eradicated in a terrible way by killing the cattle. But we've only eradicated one infection in humans, and that is smallpox. But it had 4 distinctive features that allowed for its eradication. And those 4 distinctive features, it had no animal reservoirs. It had clear pathogenic features. Smallpox only looked like itself. It had a short period of infectiousness, and the vaccines or getting infected made you immune for life. Unfortunately, COVID-19 doesn't have any of those features. About 29 species of animals contain COVID-19. There was an attempt once in Denmark to kill mink. They killed 17 million mink who had COVID, but you can't kill animals and eradicate something that has 29 species of animals that carry it. It looks like a number of other respiratory illnesses. It doesn't have pathognomonic features. It looks like the cough, shortness of breath of other respiratory illnesses. It can spread when pre-symptomatic. And even though our vaccines are amazing to protect us against severe disease, they do not protect us against every infection. They are not what we call sterilizing. And so that ability to get to control, I think, also requires treatment as well as vaccines with COVID-19. Because if we look at, for example, measles, we've managed to control measles only with a vaccine. It's a virus. Unfortunately, measles is getting out of control in some places because of setbacks in the vaccination response during COVID-19. But a treatment like an infection like pertussis, which is a bacteria, actually is controlled by a vaccine, but we also, in those who are susceptible, have an antibiotic, macrolides. For example, for neonates or older people who get pertussis, we have an antibiotic that helps control it as well. And I think that's why Paxlovid is such an important treatment. I'll actually skip molnupiravir in the interest of time, but Paxlovid is a treatment for COVID-19. It is a protease inhibitor. It was specifically designed to combat COVID-19. And we know that it works among unvaccinated people at high risk of severe disease because that was a randomized trial called EPIC-HR, 89% protection. But we also know that it protects vaccinated people against severe disease. But who does it protect? Well, this was a very large adjusted observational analysis in the New England Journal from Israel. And looking across the Israeli healthcare system, it looks like those 65 and older were those who benefited if you were vaccinated from getting Paxlovid to prevent hospitalization and death. There was actually no benefit from those 40 to 64 years old, which again is our theme. Who is most at risk now of COVID-19 and of severe outcomes? It is older individuals. They need boosters, they need Paxlovid, and they need to be protected. I will actually end with the point that because many of you are working in the medical field, you are healthcare workers, you are pre-medical, you are medical students, you know the importance of trust in our providers. And the trust, unfortunately, throughout the pandemic in public health has fallen. There's actually 32% of Americans trust the CDC. But providers have strong relationships with their patients. And it is those one-on-one interactions. It is that provider to patient interaction where we can advise on the vaccines, where we can talk about therapeutics. And it is, you are the future. You are our rescuers from all the polarization and all the problems that happened with communication during this pandemic that led to this loss of trust in public health. And why is this loss in trust of public health important? Because it's made the US lose trust in other vaccines. And we've seen polio for the first time circulating in New York. We've seen a measles outbreak in Arizona. We are not where we need to be with trust in public health, and you are the future to save us. I actually would love to take questions on COVID and then go on to monkeypox, unless you'd like me to specifically cover the pediatric vaccines. So let me know.
I think it'd be nice if you cover the pediatric vaccines.
Should I go to
and
cover the
then we can move
pediatric
on to
vaccines?
monkeypox.
Okay, I'm sorry. Did you say skip the pediatric vaccines?
Let's go cover it, please.
Let's go cover it. Okay, so let me talk a little bit about the pediatric vaccines, and then we'll do monkeypox. So, the pediatric vaccines essentially came out later than the adult vaccines, and I'll send you all these slides so that you have these. But the reason is because older people were so much more at risk, and because and unfortunately, which I won't go into here, we all know the history of school closures. And I think the school closures, and I don't think I've been, I guess, shy about that in the news, but I do think the schools were closed way longer than they ever were for any pandemic and shouldn't have been closed this long. So what do we know about pediatric COVID vaccines? So essentially, they are smaller doses. So the dose that we use for adults and 12 years and up of the Moderna vaccine is 100 microgram times 2 shots. And actually, the Pfizer vaccine is essentially 30 micrograms times 2 shots. So this is actually incorrect. Sorry, the 100 micrograms is the Moderna and the 30 micrograms is the Pfizer. So this bottom line is incorrect. What about younger? So this thing got this. I'm gonna actually correct this. Sorry, this thing got completely messed up. So this actually goes here. And this is 30 micrograms of the Pfizer times 2 shots. Okay, sorry about that. And then 100 micrograms of the Moderna. And I don't know why this table got out of whack. I'm sorry about that. I want you to have the right doses. And the Moderna is 100 micrograms, and that's for adults. Okay, so the 5 to 11-year-old dose is, and this really got all messed up, but is 10 micrograms for the Pfizer vaccine. And then for the Pfizer vaccine for 2 to 4-year-olds, we use a much smaller dose, which is 3 micrograms. But 3 micrograms times 2 shots was not enough. So it actually requires 3 shots of the Pfizer vaccine for those between 6 months and 4 years. And then of the Moderna vaccine, it's a 25 microgram dose times 2 shots. And when I send this to you, I'll correct this table. So what do we know about the effectiveness among children, 5 to 11-year-olds? Well, I wrote a piece in Time magazine on November 3rd, 2021, where there is a big debate in this country about the childhood vaccine. And I wrote with a pediatrician where we said we still believe that children should get the vaccine, even though they're much, much less at risk for severe COVID, which is sort of a strange aspect of this infection, but it has to do with the fact that the immune response protects young children very well, which isn't true of measles, pertussis, and other major infectious diseases. But we wrote this piece at the bottom saying the childhood vaccine debate ignores a crucial point. No child should die of COVID-19, meaning get your child vaccinated because any protection against severe disease, even if they're much less at risk of severe disease, is important. However, to be fair, there hasn't been the uptake in this country of the 5 to 11-year-old vaccine that we thought there would be. And essentially at this point, about a third of children 5 to 11-year-olds are vaccinated. And the uptake specifically of those 6 months to 5 years is even lower still at about 15%. So why have people not uptaken the childhood vaccine? I think there are 2 reasons. One is that it's true that children are much, much less at risk for severe disease. Second is that there is a concern about myocarditis, which I'm going to tell you about in a moment, which is an adverse effect that of the vaccines that mainly occur in young men between the ages of 12 and 30. And the third reason is whenever you see papers now that look at the effectiveness of the childhood vaccine, you don't have a control group of people who are non-immune, of children who are non-immune. As I told you, 86% of children in this country have been exposed to COVID-19. So the comparison group has natural infection. So the vaccine does not look very effective at all because you're not comparing it against a naive population. So as we've gone on with time, all the vaccines have looked less effective compared to natural infection because there's been so much natural infection and the clinical trials in children were done later than adults. So what about in young children, the different side effects? Well, I told you that the pediatric Pfizer vaccine is 3 micrograms and the Moderna vaccine is 25 micrograms. And concomitantly, there were more adverse effects in children who got the Moderna vaccine that was at a higher dose. There was actually more fevers. There was more systemic reactions. There was more local reactions in the arm for the children. And so I actually, if I were to choose, and if I had a young child, I would definitely give them the Pfizer vaccine because it had much less side effects. I do think that 25 micrograms may be a little high for a 6-month to 5-year-old, or at least as judged by the trials in terms of more side effects. And what do we know about myocarditis? Well, I already told you that extending the interval between doses was the best thing that we could do with effectiveness. Unfortunately, the US never recommended 8 weeks between doses. They recommended what Pfizer had studied these doses at, which was 3 weeks. But actually, this was a study in Cell in October 2021 that showed us that extending the interval on the Pfizer vaccine of the first and second doses to 6 to 8 weeks increased both your antibodies, but importantly, your T cells. And that's what we want to increase is our T cells because those are our long-lasting immunity. And so what the UK, Canada, and India did is they actually did all of their first and second doses 8 weeks apart, except in very high-risk groups. And they saw much less reinfection during the Delta variant surge than we did in the US, likely because they had stronger immune responses with the 8-week dosing between the first and second doses. Not only did they have more effectiveness with extending the duration between doses, but they actually had more safety in that higher risk group for myocarditis from the mRNA vaccines, which is again males between the ages of 12 and 30. They had about 4 times less mild myocarditis cases in their young men than we saw in this country with the shorter interval between doses. So I recommend for any parent getting their child vaccinated for the primary series, even though this is again not what the CDC stresses, but I think they should, a longer dosing interval between doses. And I have 2 sons and I got them both vaccinated with 8 weeks between their primary and second doses. The CDC did change that duration to 8 weeks. Finally, we wrote several pieces actually trying to persuade them to change it. And they did change it, but they don't advertise it very well. They say 3 to 8 weeks, but every other country is strongly recommending 8 weeks, especially for young people. So I'll end there actually with COVID and take questions before we go over to monkeypox, because I'd love to hear any questions that you have about COVID-19.
Right. Oh, thank you, Dr. Gandhi. It was a great presentation and appreciate you kind of enlightening us with some of this information. I'm looking at the chats. I don't think I see any in the Zoom at least, but we do have some questions prepared. So I guess the first question would be, what is the effect of, or what role do these boosters have on herd immunity, if at all, at this point?
Well, that's a great question, because the other reason that we were really trying to persuade parents to vaccinate their children early on was this concept of herd immunity, this concept that we could get everyone immune and protect others. Now, unfortunately, these vaccines, the antibodies do decrease pretty quickly. We don't know how long it will take for the Omicron specific booster antibodies to decrease, but we have found increasingly that unfortunately vaccines don't reduce transmission to the same degree that they did during the Alpha variant surge. Why did they decrease transmission so well during Alpha variant? Because we had really high antibodies. We had just been vaccinated. We had never seen the virus before. So really high plump antibodies that protect you up in this area. And thus you can't even get infected to spread it, even mild infection to spread it. And the second was that the antibodies worked really well against the Alpha variant. And those antibodies started working less well with the old booster against the new variants. This particular new booster does create higher antibodies against the Omicron variant, but unfortunately that effect by the Pfizer data that was just released yesterday was only seen in older people and over 55-year-olds. So if the neutralizing antibodies don't get driven up in an 18-year-old, say, then that isn't going to actually protect others by decreasing transmission. And so I know that there's some colleges mandating boosters for young people, but I'm not seeing the scientific justification for that, either protection for the 18-year-old or unfortunately even protection for others, because of the Pfizer data yesterday showing us that it did not drive up neutralizing antibodies, Omicron specific BA4, BA5 neutralizing antibodies any more than the old booster. It did again drive it up in older people. So yeah, that's the answer to that, unfortunately.
Can I make a comment?
Please.
Yeah, this is Dr. Felizardo. I'm infectious disease specialist, private practice in Bakersfield, California. So, by the way, excellent talk, Dr.
Thank you. Thank you.
Let me just add two things to that. I think the main problem is the BQ.1.1 subvariants.
Right. These new variants are coming out. Yes.
Yeah, in August, it's the BA5 was about 85%, and now it's about 40%, and BQ.1 and BQ.1.1 from less than 1% is now 40%. So the question is, would a bivalent vaccine work against the BQ.1.1? Now,
exactly.
You mentioned.
Exactly. Yeah, no, that's another great question. These variants keep on coming out so quickly. Can we adapt the vaccine fast enough? It's a very good point, because the neutralizing antibodies that were measured in the Pfizer press release yesterday were only against BA4, BA5. They did not look at BAQ1, BAQ1.1, or XBB. And so I think those need to be looked at with the Omicron specific vaccine. Absolutely.
Well, there was actually two studies just came out. One is from the Shi lab from University of Texas, and the other one from the Sutar lab from Emory University. And they actually check it against BQ.1.1. And in the Shi lab, there was a threefold improvement over the original. This is live virus
original booster.
Threefold increase. And in the Sutar lab, according to Dr. Topol, it's 10-fold increase. Although my calculation is 6-fold increase. The problem is, if you look at the GMT, the geometric mean titer, it was only 112 for the Sutar lab and 27 in the, I think 73 in the Shi lab. So although if you have a hybrid immunity, it goes to 267, but this should be more than 1,000. But the good news, though, is in France, where BQ.1.1 is the main dominant variant right now, there's no increase in deaths. And
no, that's true. And in the UK as well, and India had BA.2.75 at very high amounts, no increase in deaths. I mean, this is why I really wanted to go over immunology, right? Like the T cell response is so protective against all these variants that we have to decide who the booster most benefits. And any booster increases antibodies, right? Any booster or infection will increase antibodies, but who needs that booster the most? And that's why I showed that Lancet UK paper, the 30 million people. It really, and why the WHO is pushing us to only boost older people.
And there's actually one study that just came out November 1st. It was in Science Immunology. They actually shown that the interferon T cell response 6 months after COVID vaccination did not decrease.
Exactly.
And interestingly, when they gave the booster, it did not even increase it.
It did not even help boost. I saw that Science Immunology paper, and I think that's really important. Like, I think what has decreased the trust in public health in this country is I have an opinion, but I think it has to do with kind of pushing endless boosters. We need to rely on our immunology response and really go back to principles of immunology to figure out who needs boosters and figure out who's most protected. And so I think these are all very good points. I have very little time, so I want to do monkeypox super quick. Can I do it really quick? Because I don't want to.
We actually have one more question for Dr. Felizardo.
Okay, please.
That's okay before we move on to monkeypox. Yes. So after receiving Dr. Gandhi's perspective, we would like for Dr. Felizardo to share his own experiences of knowledge of COVID response in the Philippines and his own personal experience as a member of the Filipino community, especially with his work with OCTA, which he can talk about.
Please.
Oh yes, so I'm unpaid consultant for the OCTA group.
For the Philippines.
It's actually a private group in the Philippines that they actually did a decent job of forecasting the Delta and the Omicron waves in the Philippines. So they gave adequate warning to the population. So that's my contribution to the Philippine
It's
COVID
great that you're
epidemic.
doing that.
Yeah, but in here though in Bakersfield, I have I'm an infectious disease specialist. I go to 5 hospitals. I've treated more than 1,000 critical COVID. I lost co-manage 200. So we have like 20% mortality. The good news is every 6 months I'll have 50 deaths, right? But in the last 6 months, I have 0 deaths in Bakersfield, 0. So that's good news. And I think because of the hybrid, I think the hybrid immunity is working well. We are not immunologically naive anymore to COVID. So I'm pretty optimistic, even with the advent of the new Omicron subvariants, that we will do well. I think the hybrid immunity will make a wall. We will not have herd immunity, but we'll at least have herd safety.
Totally agree.
Herd safety
Totally
rather than herd immunity.
Totally agree.
Thank you.
Okay, so and thank you for all your work. That is so great that you do so much work in the Philippines as well, and be a unpaid consultant. But you're right, we're at a very different point in the pandemic, which is I think why the WHO is trying to urge us to figure out who needs the boosters and who needs treatments the most. Okay, so monkeypox was a surprise. Let's just remember what monkeypox is. We really have to remember that we have 3 different types of viruses. We have DNA viruses, we have RNA viruses, and we have retroviruses. And HIV is a retrovirus. It's an RNA virus that goes into a DNA virus, makes DNA in the human body, then intercalates into your human host cell chromosome, and then you can't, unfortunately, cure it. We've only cured 4 people through bone marrow transplants. So, I mean, you live with it for your life. And then SARS-CoV-2, polio, measles, those are all RNA viruses. They can't get into your host human chromosome. And then there are the DNA viruses. The main, like herpes DNA viruses, for example, can stay latent in your system. But what is monkeypox? Well, it's an orthopox virus, and it's actually part of a very small but very famous family, because the orthopox viruses include the smallpox vaccine, which is variola, which is now eradicated, the smallpox virus, which we talked about, vaccinia, which was used to make smallpox vaccine, and also cowpox viruses. So it's kind of a rare family, the orthopox virus. And it was first named, unfortunately, because there was a outbreak that occurred in monkeys used for research in 1958. And that's why it got this name, which I don't like this name. No one likes this name, monkeypox. But it is closely related to smallpox. And we did see human outbreaks, but usually from rodent exposure, but we really only started seeing those human outbreaks once we stopped mass vaccinating for smallpox. So smallpox was eradicated in the world in 1980, in this country in 1970. We stopped all of our mass smallpox vaccination programs. That immunity wore off because smallpox vaccine and smallpox infection is cross-protective against monkeypox. And then we started seeing outbreaks in West and Central Africa, where MPX is actually found in animals, in rodents. And so these countries in these regions have been more susceptible to endemic outbreaks in the past decade. Now, we did see some infections here in the US, mostly within returning travelers. 2021, we had 2 returning travelers from Nigeria that where MPX was seen. But in 2003, we did have a very strange outbreak here in the US because there were these infected rodent animals brought from Ghana. They actually mixed with prairie dogs. People buy prairie dogs as pets, and these infected prairie dogs did give this MPX infection to 71 people in the Midwest. And that was the last time that we had a big outbreak. But what about this new outbreak, and why did this happen, and how did this come out of the blue? So let's talk about this global outbreak. Well, this global outbreak started on May 2nd. I shouldn't say May 12th, sorry. May 2nd was the first case report to the WHO of the monkeypox outbreak. It was from the UK. And since then, we have seen over 80,000 confirmed cases, mostly in about 109 countries. Never had seen this before. And early cases were in the UK, then Europe, then Canada, then Australia, then it came to the US, which had the highest rates, then it's most in Latin America. And really this infection, this monkeypox outbreak has mainly been occurring in overwhelmingly gay and bisexual men. If you look at this curve here on the right, most of the infections have been in male. It's been about 98 to 99% male. And it really does seem to be from close sexual contact. We used to think it was close respiratory or skin-to-skin contact, but increasing evidence is that this is most likely a sexually transmitted disease, and I'll talk about that in a minute. The cases have absolutely started slowing, but we had quite a swell throughout July. Really, the peak of this global health emergency was on July 23rd when the WHO declared it a global health emergency. But since the end of August, we've been seeing the cases go down across the world. And that's likely from natural immunity within this population, changing of behavior and multiple sex partners, and the dissemination of the smallpox vaccine. In terms of the US outbreak, we did have the highest number of cases here in California, and we still are leading the country, but we are absolutely seeing decrease in cases here in California. And what are the symptoms of the infection? Well, this was one of the largest case series, but it was eclipsed by another one in the CDC. But this was really the first case series in the New England Journal, 528 individuals, was published in July. It was mostly men who had sex with men, 98%. It was 75% white, and it really was mostly skin lesions, and 95% and 73% of those lesions were in the anal and genital region, which could be very painful and very, very uncomfortable. And they range from flat to blisters to clustered lesions. They really are pox-like viruses. And there were systemic features in 62%, including fever and lethargy and muscle aches. Here's an example of some of those lesions. Sorry to show you these, but they're important to look at. They're important to see that they can be in different stages of progression. And it's when you crust over the lesions that you're no longer infectious. And then the biggest case series was really published from the CDC MMWR from May to July. This was, again, 99% men, 94% reported same-sex activity. There is an decreasing rate in white men and an increasing rate in Black and Hispanic men. And 41% of these men had HIV, which is very unusual because 41% of gay men do not have HIV. There seems to be some enrichment. Remember, we've never seen an orthopox virus and HIV simultaneously overlap. Smallpox went away before we saw the first case reports of HIV described in 1981. So there seems to be some interaction between monkeypox and HIV. And in fact, those with HIV at least those with uncontrolled HIV, tend to have more severe disease from monkeypox. We're more likely to be hospitalized. We're more likely to have severe lesions. There are also high rates of concomitant STDs that come along with the monkeypox outbreak. So always screen people for STDs, other STDs, along with monkeypox. So why in my opinion, should it be reclassified as a sexually transmitted disease? And I wrote this piece with others, including Jeff Klausner and Gail Bolin in September, saying that a position statement on monkeypox is a sexually transmitted disease. Because even though there have been rare transmissions to children, probably from close contact with parents, there are 3 sexually transmitted infections that are still called STDs, but they can still rarely spread from contact. For example, herpes. If you touch a herpetic lesion with your hand, it was called herpetic whitlow. In healthcare workers, we can get herpes lesions. Before we universally gloved in genital examinations, healthcare workers could get syphilitic lesions on their fingers. And molluscum contagiosum is mostly sexually transmitted, but it can also spread from just touching the lesions. So there is rare spread of monkeypox from close contact with lesions, but the majority of the transmission is from STDs. And that's why we really put this position paper out saying that we think it should be called an STD, because then resources can be directed appropriately. And in fact, New York City just 2 days ago reclassified it as an STD, which allows money for sexually transmitted diseases from the federal government to be funneled to monkeypox. It also allows adolescents without getting parental permission to be treated in STD clinics. And Other evidence why this is really a sexually transmitted disease. Well, this is a piece from Eurosurveillance, but it showed that viable virus, monkeypox virus, is found in anal and urethral swabs. So it really is, it really does seem to be sexually transmitted, and mostly from gay male sex. So what about the vaccine and how well does it work? Well, it's not a monkeypox vaccine, it's a smallpox vaccine, but it works really well against monkeypox. And why do we know that it works well? Well, the main reason we know it works well is what I told you before, that fundamentally we didn't start seeing monkeypox outbreaks in endemic regions where it's found in animals in West and Central Africa until our smallpox vaccine campaigns had worn off. And then this is a paper from the Democratic Republic of Congo, was called Zaire at the time in 1985, that showed that the estimate is that the smallpox vaccine is about 85% protective against monkeypox. And we have the AKM 2000, which is caused more side effects. So we're really pushing the Jynneos vaccine, and that's been the vaccine that's been most used in this outbreak. And as I told you early on, since the 3rd week of August, we have seen massive declines in the cases, both worldwide and in the US. In fact, the WHO does believe it will be eliminated in regions of these outbreaks worldwide. Eliminated means, remember, not eradicated across the planet, but eliminated across regions. And I do think it'll probably be eliminated here in the US, but that doesn't mean it's going to be eradicated because it's in animal reservoirs in West and Central Africa. And as we've been giving out the Jynneos vaccine, which we've done a very good job of in this country and in Europe and the UK, we have to say, and this is a terrible echoing of history, we've actually not been giving this vaccine to West and Central Africa. And the places where it can't be eradicated, they have not been receiving vaccine. So we've given out 1 million doses here in the US. It's 2 doses. We were giving intradermal administration because we had very few doses and there's a lot of antigen presenting cells in the skin. And so in August 18th, the Biden administration said, let's give it intradermally because maybe we can give less. We can give 0.1 mil instead of 0.5 mils and get more people protected because we had a vaccine resource scarcity. Now California DPH has gone back to recommending that we can use it subcutaneously because we have much more vaccine supply. And I do think that a lot of people need to be vaccinated. I think anyone who's at a risk for HIV infection or should be on PrEP should be vaccinated for SARS-CoV-2. That's about 1.2 million people, and then that's 2 doses. And any man living with HIV, I think, should be vaccinated against monkeypox, and that's about 648,000 in this country. And so we have accelerated dose production here in this country, and we do have a much better vaccine supply now where we are. In terms of diagnosis, we diagnose it by actually swabbing a lesion. Very rarely this has been seen. The PCR does not work. There's been a deletion that's occurred in the tumor necrosis factor receptor gene which is the target for the PCR test. And very rarely that we've had some false negatives, but it really is monkeypox, in which case you should send that to the state lab if you suspect that it really is monkeypox. And then finally, in the interest of time, I'll just end with tecovirimat. Tecovirimat is really the only drug that's approved for monkeypox. And when I say approved, I don't really mean approved. What I mean is that you can get it for compassionate use from the CDC by an IND process for severe monkeypox cases. And why did we know it worked? Well, we do give out smallpox vaccine to the military. And because of that, there have been some rare eczema vaccinatum or severe risk factors from giving out a smallpox vaccine, because smallpox vaccine is a live vaccine. And so we've had to use an antiviral in people who got these vaccine reactions, and tecovirimat seemed to work. So it is approved for smallpox vaccine reactions, and it is approved for smallpox. Of course, we haven't seen smallpox, but it is approved. If there was an event, it is approved for smallpox. And then what do we know about its use in monkeypox? Well, just kind of case reports. For example, this is in the Lancet ID, and one person was treated with tecovirimat in this current monkeypox outbreak, and they did well. Now, they may have done well anyway. That is the natural history of infection, but there was shorter viral shedding with tecovirimat. And then there was another case series in the New England Journal that 2% received tecovirimat, and they just said it was essentially safe. They couldn't tell if it was effective. So we really need to study its effectiveness. And at this point, we do have a clinical trial, and I'm going to forward to that. This is called the ACTG A5418 or STOMP trial, which is a randomized controlled clinical trial that the NIH is funding to randomize between getting placebo or tecovirimat for monkeypox. And if you have very severe disease, we should still be getting compassionate use tecovirimat from the CDC. But if any, there's just some monkeypox lesions, not too widespread, not in very sensitive places, we really should be randomizing people into this trial so we could see how well it works. Now we're having a hard time randomizing people into this trial because the cases have decreased so much, but we are a site here at UCSF and we would encourage this. And I will end there and see if you have any questions on monkeypox, or we could discuss it. Did you see a lot down there? Dr. Pelzario, we saw a lot here.
Yeah, I'm in Bakersfield. I diagnosed 5 patients from July to October.
Okay.
My first one had a travel to Spain, but he had a smallpox vaccination, as a child. And he
That
only
helped.
had 2 non-tender lesions. And then the second one, he had a genital lesion with edema. So I treated him for bacterial superinfection. But
Okay.
the last one in October, he had like 50 lesions all over and he presented with anal pain. So we have to hospitalize him. He has advanced AIDS, non-adherent medications.
That's the risk group, yeah, for that.
We treated him with tecovirimat 600 milligrams twice a day for 2 weeks, and he did well. Yeah,
Okay.
but a significant number of my patients now have intradermal vaccination.
Vaccines, great. Yeah.
So,
We saw a huge amount of monkeypox because we have an HIV clinic. And so we really did see a lot in July, but it all went away. We're hardly seeing it now.
And also the CDC, I think there was an article showing that the protection rate is 14 times higher compared to unvaccinated. So it's pretty good. Plus, smallpox vaccination, there was a modeling study showing the decrease is only 1% per year.
Exactly.
And protection against severe disease will last more than 50 years. So at least
smallpox vaccine is a good vaccine. Yeah.
Well, also, there's not much difference genetically between all the orthopox viruses. That's why there's, the vaccine works for it's a vaccinia virus. It works for smallpox and works for monkeypox.
Yeah. So any other questions about monkeypox or anything else?
Hi, I am curious to know, thank you again for your great presentations about both the COVID vaccines and the monkeypox outbreak. And it's good to see kind of the epidemiology curve come down on monkeypox in such a way where, rapid responses, early access to vaccines and public awareness can really kind of then change the curve. One question I had is something that, some people have asked me. So for example, in the Philippines, at least in the beginning, they had mostly Sinovac and Moderna and a little bit of AstraZeneca for vaccines that were available. And a lot of times in the Filipino community, people might have their parents or themselves living in the country and then coming to live in the United States. And when it comes to all of these updated bivalent boosters and things like that, for people whose primary vaccine dose is something that's not available in the US, like Sinovac or other things like that, what's the recommendations for people to get boosted when they're here, especially for those who are higher risk?
I think that's a great question. I think that anyone who got a whole virus vaccine like Sinovac or Sinopharm, though I think they're good vaccines, they're not as good as the mRNA vaccines. And in fact, the WHO recommended 3-dose series for those early on instead of 2 doses. So anyone who's had Sinovac or Sinopharm, I would get an mRNA boost here, and you might absolutely get the Omicron specific one. Sputnik 5 is actually another one that was disseminated pretty widely. Russia before this latest was was giving out this everywhere. And Sputnik 5 is actually a good vaccine because to think of it as a Johnson & Johnson or an AstraZeneca, the DNA vaccines seem to produce a really strong T cell response. And we have seen people with Johnson & Johnson do well. It's just that we probably shouldn't have given 1 dose of Johnson & Johnson. It really needs to be a 2-dose series. So I think Sputnik 5 is okay if they've gotten 2 doses. I just advise someone to get an mRNA on top of a Sputnik 5 because Sputnik 5 isn't recognized by our country. And that's one problem. I think it's a good vaccine, but it's just simply not recognized by this country. And then Covaxin is another whole virus vaccine in India. I think that's a great vaccine, but again, the whole virus vaccines I'd supplement with mRNA. Any other? And I know I got you all late by starting late, so I really again apologize by that from that.
No worries. Yeah, maybe one more question. If you could talk, Dr. Gandhi or Dr. Sarta, if you can talk about what role does the booster have in terms of long COVID risk? Is that something that needs to be considered? And like, what would you recommend for those situations?
Dr. Filizar, you want to take that?
Well, definitely there's some data that there's decreased long COVID after vaccination. But that's, just with 2 doses. We don't have data yet if, if there's an advantage with giving a booster in decreasing long COVID.
I agree that there was a big study from Israel that showed that getting 2 doses of the vaccine, you had the same incidence if you got super infected with COVID after that of long COVID than you had if you had never had COVID at all, meaning people's describing getting COVID, not having COVID at all, nucleic capsid antibody. I'll send you that paper. You can tell by nucleic capsid antibodies, not getting COVID at all is not a good thing. Sorry, they had the same side effects and long COVID symptoms as if you had had 2 vaccine doses. So I think vaccination is very protective for long COVID. And then there was another study in JAMA that a 3rd dose, if you have long COVID symptoms, reduces those symptoms. So it makes sense because adaptive immunity really controls the kind of inflammation and the innate immune response, which is associated with long COVID.
Thank you. And then maybe one more question, if that's okay with you all. What can you expect in the next few months in terms of COVID surges, infections, hospitalizations? I know you talked a little bit about this, but coming into the winter season, what would you expect?
I mean, that's what we were really talking about. I'm really feeling good that we're in a good place with COVID because of the high degree of population immunity. It's really a combination of vaccination rates, hybrid immunity, getting infection on top of it. We are also, like you, seeing very little severe disease in the hospital. We've had probably 1 COVID severe respiratory pneumonia in the last 3 months. And so I think we're in a good place worldwide with these high degrees of COVID immunity. We're never going to get rid of it. Older people are always going to be more susceptible, like they are to influenza, like they are to RSV, even to adenovirus, to other coronaviruses. And we're always going to have to be boosting and thinking about treatment for older people, but we have tools and we're doing well.
Yeah, there's a forecast. I think there's one forecast showing that by January 2023, about 90% of the Omicron subvariants will be BQ.1.1, and of course, XBB is not the problem here right now. It's more of a problem in Asia. But I think the at least 95% of the population in the United States have either vaccinated and or infected. So we have great hybrid immunity. There's one study showing that even if you adjust for the waning of the immunity, 75% of the US population has great protection against even against symptomatic COVID. So we should, I mean, the cases probably would increase a little bit, but I don't think the death rate will increase even with the BQ.1.1 surge coming in.
Exactly. I agree.
Great. Thank you so much. And then I think Dr. Palma, you wanted to talk a little bit about some of the vaccine resources and a little bit about Tayo Help Desk.
Sure. And so thank you again, Maring Sama, Dr. Gandhi, Dr. Sarta. I just want to thank you all for being here today. And so thank you also to Matt Rosas, Diana Del Rosario, who are amazing co-presenters and moderators for today's event through the Council of Young Filipinx Americans in Medicine. This group was brought together by PhilProsTayoHelp.com, which is a culturally tailored resource for Filipino Americans during the COVID-19 pandemic. And so we've been able, throughout this whole pandemic, been able to go through a lot of, community webinars for education, as well as holding various vaccine clinics. Our next clinic will actually take place in Miami, Florida. It's called Working Together with Nanay, which is a group based out of Miami, in order to kind of talk about all of the different Filipino nurses and all of the different groups that are able to get together and help to bring the community together, as well as to make sure that everyone is protected in the ways that they are, especially for primary series for our elders. And I will be able to drop a link in the chat to our next bivalent booster shots and flu shots. It will be at the Nainay Community Center at 659 Northeast 125th Street in North Miami, Florida, from 9 a.m. to 6 p.m. Eastern Time on December 3rd. And then one more thing I wanted to share is just how folks can get connected to tayohelp.com as well. So I'm just going to share my screen for just a second. All right. Okay. So for those of you who haven't yet visited our website, tayohelp.com is our own help desk built out of the Zendesk help desk platform, drawing on the major call center industry in the Philippines and having that work for Filipino American public health. It's been live since October of 2020, and we hope that you tune in, follow us on social media as well. Again, we've been holding all of these different booster campaigns. We've had some TikTok campaigns, including the Vax to School campaign with the Department of Health and Human Services, We Can Do This, as well as making sure everyone understands that the things that are in the COVID vaccines and in the updated booster shots are very much coming all together in a way that, is driving in ways that our community understands. And so for anyone who's looking on how to get their updated bivalent booster for COVID-19, that one of the easiest ways to do is to go to vaccines.gov. Again, that's vaccines.gov. You can also text your zip code to the phone number 438829. And you can also call the national toll-free number 1-800-232-0233. And so all of these will help you figure out, where your local COVID-19 vaccine will be. These are the ones located within within like a 25-mile radius of Pomona, California, for those of you in Southern California. And for those, so just remember again, vaccines.gov, or ask any of the people on this call, and we can try to help connect you to one of our own Tayo vaccine clinics. And I will pass it back off to Matt and Diana.
All right, thank you everyone. Thank you again to our presenters and our panelists. And again, thank you for GMA Pinoy TV and reminding us that we are stronger together. And with that, I'd just like to cue our last little video we have with GMA, especially coming in the holiday season, just reminding us that we are stronger together. And thank you all once again. So go ahead, Lizelle, you can go ahead and play that video. All right, thank you everyone. That is all we have for you today. Go ahead and check out all the links, and thank you again to all our presenters and all our panelists. Thank you. Have a great day.